This is basically an ongoing clinical trial. So for today, I'm basically going to take you through the rationale for the trial, as well as a little bit of kind of the design of the trial. So just to get started, a few relevant disclosures. So you guys have heard about TULSA. What is TULSA? TULSA is essentially kind of two components. There's a urethral applicator that has 10 individual ultrasound elements that are placed through the urethra. It's guided, it's mated to a robotic arm. You can individually control each of these 10 elements and they fire directional ultrasound. This rotates so you can treat essentially 360 degrees within the prostate. There's a rectal cooling device. And this is done in the MRI machine. So it's done as a closed loop system. Every 5 seconds or so, you get an MR thermometry image, you get a temperature map of the prostate, and that's used by the software to figure out how much you've treated, whether you've hit your margins before it continues to go. So this was the initial TACT trial. This led to FDA approval. This was back in, I think, 2019. This is a multinational trial, 115 men. A third of them had low-risk disease. Two-thirds of them had intermediate-risk disease. And, going back to the whole-gland discussion, a lot of these patients had bilateral disease or greater than 5 positive cores. So this was whole-gland ablation with urethral cooling. It was only one cycle was allowed. So, we can probably discuss that later if there's questions about the pros and cons of one ablative cycle. Primary endpoints was PSA reduction and adverse events at 1 year, and then the 5-year outcomes was we were looking at volume, prostate biopsy, as well as some of these other factors. So, the AUA guidelines really says, look, we're still having a dearth of kind of randomized controlled trials. We really need these in this setting, especially if we want to incorporate ablative technologies into guidelines. And I think this is a good trial to address that. So what is the rationale for these head-to-head comparisons between TULSA and RALP? So this is the 5-year outcomes of the TACT trial. So overall, we see a quite stable reduction in PSA after whole-gland ablation. Going down, you usually see about a 90% decrease in your PSA. We said 92% volume reduction on MRI, and if you have a negative MRI, it's a 96% negative predictive value for absence of kind of intermediate risk prostate cancer in 1-year biopsy. At 5 years, 21% of men have proceeded to salvage prostate cancer treatments. There's no unexpected complications. Because these men were on the TACT trial, they were not able to undergo additional TULSA. They either went for radiation or surgery. And you can see that this actually compares quite well to kind of other studies out there for radical prostatectomy for intermediate risk prostate cancer at 5 years. So when we then look at the safety outcomes, quality of life is favorable and stable to 5 years. So there's a majority of men had preservation of potency, in the high 80s. There's no severe adverse events for grade 3 or severe for 2 to 5 years. Most of these were kind of early issues with, infection or retention. 87% of previously potent patients reported erection sufficient for penetration. And this has actually increased over time from 75% at 1 year. And it's a long-term durable urinary continence. 97% of these patients have preserved urinary continence, and 92% remain completely pad-free. And this is out to 5 years now. So this is the CAPTAIN trial. It's a multinational trial. So we're looking for 201 men with Gleason grade group 2 and 3 prostate cancer. They're allowed to have multiple lesions. You can have bilateral disease. It's a 2-to-1 randomization. So out of these, for every 3 guys who come in for the trial, 2 get randomized to TULSA, 1 gets randomized to surgery. And they're stratified based on some of these other factors. We're running this at multiple sites, both here in the US, primarily in the US, as well as Canada and Europe. Primary endpoints, we're looking at the 1-year safety outpoint, which is looking at pad-free continence and erectiles sufficient for penetration, as well as this 3-year efficacy, which is looking at whether guys need additional treatment. For guys on the TULSA arm, they are allowed 1 repeat ablation if they're found to have prostate cancer residual at 12 months, as well as additional factors that we're following actually out to 10 years. So here's the study schema. Here's the eligibility criteria. You can see that some of these are probably a little bit more than what you would normally consider someone for focal. They have grade group 2 or 3 disease, PSA less than or equal to 20, no EPE. They have to be within the 3-centimeter reach of the device. They can't have large calcium deposits within the prostate and no any implants. This is the and for the TULSA arm, it initially started off as a near whole gland ablation. We've adjusted it a little bit to allow up to 50% sparing, so you can do a hemigland ablation. And then prostatectomy is kind of regardless of your institutional standard of care. Here's the 1-year follow-up. They do a 1-month diary after treatment. We do a clinical exam. There's kind of 2 penile length endpoints at the 1-month and 12-month mark for the guys on both TULSA and surgery. They get every 3-month PSAs and quality of life. Everyone at the 12-month mark undergoes an MRI plus a biopsy. Most of our biopsies are done in bore, both systematic and targeted, so we're making sure we're sampling the area of the ablation as well as the residual prostate. And the majority of these prostates are quite small, 90% reduction in volume. They then get on continued follow-up up to 3 years. And then from year 4 to 10, they get continued follow-up for salvage treatment, PSAs, quality of life, development of meds, and death. So I think multiple of you guys are in on this trial who are enrolling patients, both here in the U.S. and Canada. So it's for those guys who are in the trial, it's a hard study to enroll for, right? You're telling guys, okay, a lot of these guys coming to you for focal, and you says, well, think about surgery, right? And a lot of these guys are not going to want to be randomized for surgery. So some of the strategies we've used is to try to engage the department. We have a lot of partners who do surgeries. We want to try to streamline the process, so we'll look at patients who are undergoing surgery at our institution. We'll try to flag candidates that fit within the selection criteria. And we actually try to approach patients who are scheduled for RALPs to say, look, do you want to consider this trial? We really want to present it as equipoise. We don't know if this is truly better or not in both safety, efficacy, and actually, if you present to a lot of the guys this is for science, I actually have quite a few takers who are willing to do that. We do tell them about the TULSA technology. We share the stuff, results of the TACT trial, and they're also welcome to get it off trial with us for our clinical program. So if there's a patient who says, I don't want to be randomized, or I'm going to pull out if I get randomized to surgery, I won't enroll them on trial. So the first patient enrolled in January of 2022. 19 sites have been initiated since, and we're actually over 75% of the patients have been enrolled, so quite happy with those outcomes. Some of the other strategies, we try to incorporate the community urologists. We're activating both academic and private urology groups that have high volume prostate cancer patients, as well as actually allowing for patients to get treated at certain centers for TULSA where their community urologists can do their surgeries if they get randomized to surgery. So in conclusion, this is going to be, we're hoping as a potential one of the first level 1 evidence for safety and efficacy for ablation versus prostatectomy in guys with intermediate risk prostate cancer. We're hoping to have some preliminary results for you guys next year. And this will, I think, help support coverage for the new CPT codes that are coming out for TULSA January. I'm happy to take any questions. Thank you. Yeah.
Because the recruitment seems like a real challenge. It seems like to go find people who are on the list for radical. But how do you ensure that they, like, if you went and approach them, then you don't have calcifications or something like that, then maybe not.
Well, we still screen them, yeah. So basically, they get enrolled in trial. You do the screening. We do a CT pelvis. One of the things we do at UT is everyone gets essentially calcification screening as part of their diagnostic MRI. So if they've had a MRI at UT Southwestern, I can just look at their MRI and rule out whether they have calcs or not.
So that get off the MRI, and then so the diagnostic biopsy is anybody's biopsy, or you biopsy them, and then the follow-up biopsy involved is a different biopsy than you use to diagnose the disease.
Yeah, so that's a good question. So the biopsy, I think there's a set time limit. I think it's within the last 6 months or 12 months. It has to be both targeted and systematic, but it doesn't have to be something that we've done. So if it's from an outside center, as long as it fulfills those criteria, it's okay. For the follow-up biopsies, we've kind of done this, and I think each center may be a little bit different in how they approach it. Our rationale is if you have a 5 cc prostate and you stick 20 needles in it, you're probably way oversampling that prostate, right? So we do a few of the ablated area, and then we'll do every 4 cc's, we'll do 1 core. So we're trying to, you know, for a 30, 40 cc prostate with a 10 to 12 core biopsy, you're getting a similar density of how much you're biopsying.
Just that the people randomized to radical prostatectomy withdraw. Has there been any challenges with that?
Yeah, I don't know the data for the entire cohort. At least at UT Southwestern, I've had no one withdraw. I have to strong arm with you guys that this is a trial and you've committed to this and you got randomized to RALP. So, but so far UT have not had anyone withdraw. But I think overall it's been slower than expected. I think because you can get it off trial and we screen for guys who say they're just doing it to get it for, you know, to get it, and, you know, we try to screen those guys out.
How many patients have been enrolled so far?
So I think we're looking, I think it's over 75%. So we're looking for 201 total. So we're getting close. Yeah. All right. Thank you guys.